Good morning. I'm Georgia Davis, an assistant professor of medicine and endocrinologist at Emory University. Thank you very much for inviting me to be here today. For this presentation, we'll spend some time reviewing available diabetes technology and focusing in on some of the major recent advances in this field, including in continuous glucose monitoring and moving towards the development of hybrid closed loop or automated insulin delivery. Advance the slide for you. Again, these objectives today are to review these advances in technology and also provide a brief review of recent advances in the setting of the COVID-19 pandemic in inpatient remote glucose monitoring. I think sometimes it's helpful to take a look back and realize how many impressive advances in diabetes management have occurred over the past 100 years, beginning with the discovery of insulin in 1921. Relevant to this lecture, we see here the first insulin pump emerged in 1963. That's the picture above. It's an amazing but seems slightly impractical device. And it wasn't until the 1990s where we saw the first insulin pens and the first subcutaneous continuous glucose monitor hit the market. And more recently, we see developments in the hybrid closed loop or automated insulin delivery systems, also sometimes referred to as artificial pancreas technology. We'll begin by reviewing continuous glucose monitoring technology, often referred to as CGM. As CGM technology and awareness expands, more patients are actually asking about the possibility of using CGM for their diabetes management. So what is CGM? This picture here in the upper corner shows several of the available CGM products on the patients. A closer look at the CGM anatomy shows that with CGM, there's a small sensor that sits under the skin to measure the interstitial glucose levels every 5 to 15 minutes and correlate those with capillary glucose levels. It provides a more comprehensive assessment of glycemic control and can let patients know about impending glucose excursions or hyper or hypoglycemia with trend arrows and can help them with treatment decisions. As CGM devices continue to become more available and more accurate, patients are using them more and more. There is agreement among professional societies regarding who may benefit most from CGM therapy, including those with type 1 and type 2 diabetes who are not achieving good glycemic control, those who have hypoglycemia, especially with hypoglycemia unawareness, and also for those using insulin pump therapy. Historically, CGM technology had been prioritized for the treatment of type 1 diabetes, though there's been a rapid paradigm shift to include broader patient populations, including those with type 2 diabetes, in the setting of progressive CGM technology developments, increased insurance coverage, and lower device costs. There are three types of CGM systems that exist. First one is real-time continuous glucose monitoring, where sensor glucose values are available for visualization. They show trends and alarms, and they are sent to a CGM receiver or smartphone that the patient has consistent access to. The second is called intermittent scanned or flash CGM, where glucose values and trends are shown only after scanning the CGM sensor with the receiver or smartphone. And the third is professional CGM, which we won't touch much on today, but really no real-time glucose data is available and no alarm. It's only retrospective review of sensor glucose values from a blinded sensor, and this is often used by healthcare professionals to look at trends for glycemic control for patients over a defined time span. The most current CGM systems available in the US include the Abbott Freestyle Libre, the Dexcom G6, the Eversense implantable CGM, and the Medtronic Guardian 3 with Guardian Connect. Now we'll take a little bit closer look at each of these devices. Starting with the Abbott Freestyle Libre and its newer version, the Libre 2, we see that these are flash glucose monitors. When we look at the items on the left side of each table, We see non-adjunctive use, which means that CGM glucose values can be used without confirming with a finger stick for diabetes treatment decisions. The first Libre system does not have any alerts or alarms, which changed with the Libre 2, which has optional alarms for high and low glucose. Each system has a sensor warm-up time. The Libre is 1 hour, and a duration for sensor wear, which is 14 days. This device does not require calibrations with point-of-care finger stick glucose to maintain accuracy or reliability of the system. It is factory calibrated. And then there are also remote sharing capabilities, which we'll discuss a little bit later. But the systems can share real-time and also glucose data with clouds for reporting software. So here they have the Libre LinkUp, Libre View, and also Tidepool, which can pull together data. The Libre 2 is still pending some of these remote capabilities, but they are underway. The Dexcom G6 is a real-time CGM, not a flash CGM, and it has about a 2-hour warm-up phase, and the sensor lasts for 10 days. Does not require calibration, similar to the Libre, and also has remote sharing capabilities and reporting software on different data management platforms. The Medtronic Guardian 3 with the Guardian Connect is also a real-time CGM. It does have a 2-hour warm-up as well with a 7-day sensor wear. It does need about 2 to 4 calibrations per day. And the remote sharing goes actually just directly to that patient device, the phone with Guardian Connect, and the data can be analyzed on other data management systems such as Tidepool. The Senseonics Eversense CGM is a real-time CGM, the only implantable CGM. It has a tiny little device in the top photo that sits just under the skin, and then a transmitter that connects over that. It's a little bit different in that it requires a longer warm-up period, but the duration of sensor wear is up to 90 days. And this is done, insertion of this subcutaneous sensor is done in the physician office every 90 days and replaced. It has, again, remote sharing capabilities and also its own reporting software and interaction with other platforms such as Bluecode. So what is it that patients see? Once they decide on their system, what is it that they see? What data do they get from the CGM? These next slides will show the patient interface. So these are the 4 devices that we mentioned before: Freestyle Libre, G6, Guardian Connect, and Eversense. Here, the screens are depicted on what each patient would see. The first piece of information that's vital is the sensor glucose value, followed by the glucose trend arrow to show patients where their sugars are headed, and then also a glucose history or graph to show them the trends of where they've been throughout a certain time period. What about those remote sharing capabilities that we've asked? Many patients have a desire to share this information in real time, maybe to loved ones or a caregiver for closer monitoring. So what do these share functions actually look like for each device? On the top part of this slide, you'll see, again, the patient data depicted and what the patient will see on their receiver or smartphone. Below each device is the corresponding share program, as well as the data that's shown to the remote viewer or caregiver or loved one. So these are seen in real time. In addition to real-time share functions, the CGM data is sent to a cloud where reporting software can synthesize the glucose data and provide individualized reports on overall glycemic control and trends. Here we see that each manufacturer has their own set of data reports for the patient or provider to create. There are also data management platforms such as Gluco or Tidepool that can receive data from many different devices and create comprehensive reports. However, the generation of many unique or proprietary reports can sometimes lead to too many different reports. So how do we standardize the interpretation of CGM data? Current practice follows 2019 recommendations from an international consensus highlighting 14 core CGM metrics, with 10 shown here deemed most appropriate to clinical care. These include the number of days that the patient's actually worn the continuous glucose monitor, recommended that 14 days needed to make good treatment decisions, and to have a decent amount of that time spent with the CGM active or receiving signal from the glucose. Reports mean glucose values, glucose management indicator, which is sort of an estimation or approximation of A1C, glycemic variability, so how high and how low patients are going, and then times in range, so time above range greater than 250, time above range from 181 to 250. And a term that I think is becoming more common is time in range, so the percentage of time that those glucose readings on the CGM are within a reasonable target that we expect for good glycemic control. So that's 70 to 180 milligrams per deciliter. There's also time below range from 54 to 69 milligrams per deciliter, and then more severe hypoglycemia with readings less than 54 milligrams per deciliter. The creation of the electronic ambulatory glucose profile that includes these key CGM metrics also helps further standardize CGM reporting for interpretation. This is a sample AGP report outlining the key metrics as well as targets for these metrics, which again include active wear and then time spent in target range. So the goal for time in target range is over 70% of the time. We want to minimize time in hypoglycemia, which is less than 4% for under 70, and severe hypoglycemia less than 1%. And also the time above 250, so more severe hyperglycemia. These targets and data are also shown visually on the right side of the report, in the top right, where you have your time in target range shown how often it was high, low, or very low. Below that, we see where the median glucose values fall, and also get a sense of what's happening day to day from the daily glucose profiles. So these CGM metrics and reports provide more data for assessment of glycemic control compared to A1C alone. As we can see here on the left, two patients with the very same A1C can have very different glycemic control with high variability and lots of hypo and hyperglycemia, or pretty stable glucose levels throughout the day. However, it's important to consider, again, individualization of glycemic control targets, which has been recommended previously with A1C, as shown on the right. And this is based on individual patient characteristics, including an assessment of factors that may increase someone's rate or risk of hypoglycemia. This slide shows how individualization may be considered using time and glucose ranges. In patients who may be higher risk for hypoglycemia on the right, we may see less time in range, a little bit more hyperglycemia, but we're focusing on minimizing that risk of hypoglycemia. The standard recommendations and targets are depicted on the left. So what is the impact of using these CGM metrics and individualization of targets on glycemic control? This slide highlights the magnitude of reduction in hypoglycemia and glycemic variability among clinical trials investigating CGM use in type 1 diabetes. The top bars show the reduction in hours per day spent in hypoglycemia, while the lighter bottom bars show the reduction in variability, glycemic variability, reflected as a decrease in the coefficient of variation. This data is grouped by A1C level at study entry. You see here on the left, several studies had a higher A1C at study entry versus a lower A1C at study entry. In those with a lower A1C at the beginning, they likely had higher rates of hypoglycemia and saw very significant improvement in time in hypoglycemia and also their glycemic variability with the use of CGM. Furthermore, a recent meta-analysis of trials including CGM use in both type 1 and type 2 diabetes favors CGM use for a reduction in A1C, which is shown on the left, as well as an increase in time in range, which is shown on the right. Historically, intensifying glycemic control to achieve better A1C or glucose targets such as these has increased the rates of hypoglycemia for patients. However, further analysis within this meta-analysis showed that time below range also improved with CGM use in both type 1 and type 2 diabetes, with a bigger improvement seen in those with type 1 diabetes. So now that we see how CGM can help improve glycemic control, how can this technology be integrated with insulin delivery, specifically with insulin pump therapy? And what is the ultimate goal of that integration? This figure depicts what a lot of people are looking for with diabetes management. So we have a device that senses our glucose level, tells the control algorithm what to do with insulin delivery, and is modulating insulin delivery to achieve ideal glucose levels. Think of this, maybe similar to a self-driving car. It has a lot of different input that keeps you on the road exactly where you want to be. There have been many advances in insulin delivery, glucose monitoring, and also telecommunications and digital technology that are helping us along this journey. Before we go further into CGM and insulin pump integration, I wanted to review a little bit quickly the basics of insulin pump therapy. So what is insulin pump therapy? It's also known as continuous subcutaneous insulin infusion, and it's continuous administration of rapid-acting insulin analogs through a small plastic catheter that's just under the skin. An insulin infusion is based on pump settings that are determined by the provider, and there are 3 manufacturers with insulin pump systems available in the US. These are Medtronic, several versions. The most recent is the 670G, Tandem with their t:slim X2 pump, and also Insulet, makers of the Omnipod with the Dash system, which is a little bit different. It's a patch type pump that doesn't have tubing. Which leads us to what is the anatomy of an insulin pump? So each pump has really three components. The infusion site, or the cannula, where insulin goes into the subcutaneous tissue. It's inserted by a small retractable needle and is typically comfortable and not very noticeable for many patients. Tubing, again, that connects the insulin infusion site to a reservoir of insulin that holds about 200 to 300 units, which is a component of each system except for Omnipod, which attaches directly to the skin. Once a patient has decided on pump, how do we determine those insulin infusion rates? So this requires settings for insulin delivery to be entered by the provider, which include the basal rate or continuous infusion for long-acting coverage, can set different rates for different times or temporary rates. An insulin to carb ratio that helps calculate bolus insulin dosing to cover meals and carbohydrates. A sensitivity factor to correct hyperglycemia. A target glucose to correct high values and subtract insulin from bolus dosing if the pre-meal sugar is low. And also an active insulin time to help us calculate how much insulin a patient has on board. This is typically 3 to 4 hours. So with all of this information, how do we identify patients who may be good candidates for pump therapy? Guidelines for insulin pump therapy. Several professional societies, including ACE, or American Association of Clinical Endocrinologists, and the ADA, American Diabetes Association, have offered some guidance as to who may benefit most from insulin pump therapy. These include patients with both type 1 and type 2 diabetes who are not achieving adequate glycemic control, who have hypoglycemia, glycemic variability, either insulin sensitivity or insulin resistance, and also desire lifestyle flexibility. One important thing to remember is that patients need to be able to recognize the limitations of insulin pump therapy, and although our goal is to work towards automated insulin infusion, we need to manage unrealistic expectations that an insulin pump will eliminate patient responsibility for their diabetes management. There are potential advantages and disadvantages of insulin pump therapy. Some advantages include closer approximation of physiologic insulin secretion with administration of very small insulin doses that provides flexibility to accommodate lifestyle needs. A lot of patients find an improved quality of life, improved glycemic control, and also a reduction in severe hypoglycemia and DKA. Some potential disadvantages to consider are still high cost and need for insurance coverage to get these products. It is labor intensive. The sites have to be changed every couple of days, and the patients have to monitor for any malfunction. Some people don't like the appearance or device wear once they try it, and others may not be able to wear it due to adhesive allergies. These should all be considered when thinking about starting insulin pump therapy. So now moving back towards the goal of integrating CGM and insulin pump therapy, which is also referred to as automated insulin delivery. The progressive integration and communication between CGM and insulin pumps is shown here. Moves from sensor-augmented pump therapy in the beginning, where both devices are used, but there's no crosstalk between them, to the development of threshold suspend or low glucose suspend, where the insulin pump suspends insulin infusion once the sensor glucose value hits a certain level. Moved beyond that to say, why suspend when we're low? Let's suspend before we get low, and that was predictive low glucose suspend, or suspended insulin at some point before reaching that threshold low glucose value. And finally, the most recent integration is hybrid closed loop or automated insulin delivery, where algorithm-based modulation of insulin infusion is done according to CGM glucose values, and that includes increased insulin delivery or decreased insulin delivery, and often includes this predictive low suspend function. This is a chart that shows the available devices here, and also several that are in development. These are the Medtronic 530 and 630G, which went from threshold suspend, to the 670 and 770G that have this automated insulin delivery that incorporates predictive low glucose suspend. The 780G is in development, it's not FDA approved. Tandem has the t:slim X2 with Basal-IQ, which was alone the predictive low glucose suspend, that moved to the Control-IQ algorithm to include automated delivery and also the predictive low glucose suspend. Insulet, makers the Omnipod 5, this is in trials right now, not yet FDA approved, same thing, predictive low glucose suspend and automated insulin delivery. So we'll now review several specifics and data from the 2 commercially available hybrid closed loop systems in the US. The first hybrid closed loop system to receive approval was the Medtronic 670G. Contains an auto mode or hybrid closed loop mode that has a preset glucose target of 120 milligrams per deciliter, and it adjusts the basal rate every 5 minutes to get to that target. It does still require announcement of meals or carbohydrates, so input from the patient to give that bolus dose of insulin to account for those glycemic excursions associated with meals, but otherwise also includes the predictive low glucose suspend and a backup manual mode. So all of these devices require consistent input from the continuous glucose monitor. So if they're not getting glucose data to make those decisions after a certain point, we need to make sure that we have a backup, which are the settings we discussed earlier, and those are set specifically for each patient. This slide shows data from a single-arm, multi-center, randomized controlled trial that was evaluating hybrid closed loop with the 670G in adolescents and adults with type 1 diabetes. They were looking at A1C, improvement in time and range, and hypoglycemia as endpoints. In the figures you can see, in both adolescents and adults, there was an improvement in time and range and also glycemic variability from the study time, which is in the pink area, versus the run-in phase, where they were on manual mode without any hybrid closed loop adjustment. There was also an improvement in A1C in adolescents from 7.7% to 7.1%, and in adults from 7.3 to 6.8%. Subsequently, Tandem released the t:slim X2 with the Control-IQ algorithm, and it's shown on this slide. So this is the device in the interface that the patient sees on the left, and then we see the algorithm for how it adjusts to maintain different glucose ranges. The system has a target glucose range between 112.5 and 160 milligrams per deciliter, where it maintains those profile settings that are set by the provider, and it either increases or decreases insulin delivery to avoid hypoglycemia or hyperglycemia. And at higher glucose ranges above 180, it can also deliver an automatic bolus for correction. Here we see the results from a multi-center randomized controlled trial using this device in 168 patients with type 1 diabetes treated over 6 months. Their primary outcome of interest was the percent of time that patients spent in the target glucose range, also called time in range by CGM. And the results are depicted here. And in the top figure on the right, we see that overall time in range improved over the whole 6-month study period, with closed loop by about 10%. So we see they started at 61%, went to 71% over 6 months, and there was no change in the control group, no improvement over 6 months. Looking at the figure underneath that, we see that actually time in range was improved with the use of closed loop throughout the day, but especially at night. So without those variables of meal intake or physical activity, we see really big improvements in time in range overnight. On the left, we see improvement in A1C over 6 months. And then also all of this improved control, again, without an increase in hypoglycemia. So this is the percent of time spent below 70, which was actually lower in the closed loop group. I wanted to mention briefly this do-it-yourself or DIY hybrid closed loop systems, which are not FDA approved, but are prevalent in the diabetes community. So the We Are Not Waiting movement within the diabetes community developed out of a desire for diabetes technology to move forward and more quickly, given significant delays that were experienced around getting approval for new devices and technology for treatment, and also to increase technology access for all people with diabetes who needed this technology. It uses existing hardware, so older pumps and also continuous glucose monitors that are newer, combined with an open source algorithm. And that's depicted here on the figure on the right. So you have the continuous glucose monitor, the pump that gives the insulin, and this crosstalk between them. So the DIY models have to have some form of link that hooks up the CGM with the insulin, since it's not a product that was made to work together. So they have a little device that connects in between, a proprietary or an open source algorithm that's available that does the calculations to adjust the insulin based on the sensor glucose values. There are several pictures on the next slide here. We have one is using Medtronic and Dexcom and this link between the two that's created and sort of homemade. And then it also can be done with the Omnipod and Dexcom using Loop system. And it is known as looping. And the available algorithms and systems, there are 3. One is called Open APS or Artificial Pancreas. The other is Android APS or Loop. So going back to FDA-approved devices and other things, what is the impact of hybrid closed-loop therapy on glycemic control? This meta-analysis looks at time and range with hybrid closed-loop therapy compared to all other technologies and different combinations thereof. So we see that time and range improves on the right side. And no matter what the comparator, closed-loop therapy is the only therapy that consistently shows an improvement and significant improvement in time and range throughout all of these trials. I wanted to touch briefly on remote diabetes management, which has seen rapid expansion in the setting of COVID-19. One aspect of this remote management is the establishment of the virtual clinic, which I'm sure many people have experience with, and is depicted in this figure. So it shows how a patient with diabetes can have all of this technology. So they have meters, continuous glucose monitors, sensors, pumps, all of this data that they connect, and usually typically with a smartphone interface. And the data is sent up to the cloud, where it can be used to create reports and interact with electronic health records and be sent to providers really to use this effectively and remotely to manage patients' diabetes. They can speak with the patient, the reports can be shared, all sorts of things that are coming about since our need for virtual diabetes management is increasing. So not only has remote care in the outpatient setting taken off during COVID-19, it's actually started a movement to increase remote glucose management in the hospital setting. So the FDA during COVID sort of understood that there might be a need for continuous glucose monitoring, although it's not approved for hospital use. It's being used for monitoring to preserve personal protective equipment and try to reduce exposures to COVID-19 for healthcare providers, while still maintaining adequate glycemic control and good glycemic control in the hospital with lots of variables in sick patients. This slide sort of goes through the schematic of how remote glucose management is being implemented in the inpatient setting. So we have the CGM device, similar to everything we've spoken about before. The device is within 20 feet of the receiver, same receiver. And this receiver is connected either to Wi-Fi or a data plan where it can send the glucose data to a cloud. And again, have those real-time followers or remote viewers that now, instead of maybe loved ones, become the caregivers, the endocrinologist, the primary team, the caregivers responsible for the patient's glycemic control. It can also transmit the data to another device, such as a tablet that can sit at the nurse's station and alert nurses taking care of the patient to what their glucose values are doing at all times. And then it also, again, communicates via the cloud to create these reports where we look at how the glycemic control for that patient is truly doing over a certain time frame. So, reports over a day or 2 days, 2 weeks. These comprehensive reports can be uploaded into the electronic health record and documented. We're moving towards being able to directly input the data from the receiver, from the CGM, with the real-time data into that electronic health record as well. So integrating that in real time so healthcare providers can make treatment decisions is extremely important. And one other component that, we're still learning about this technology in the hospital setting. So using the standard of care measurements with the glucometers for point of care glucose and comparing those to CGM values intermittently is important. So we learn about reliability in clinical scenarios where we can use CGM appropriately. We have implemented this and gone one step further, so using continuous glucose monitoring remotely outside of the patient room, combined with computerized insulin and IV insulin infusion algorithm in the intensive care unit for patients with COVID-19. That's also being documented in the electronic health record. So in the top of the figure in A and B, we see the actual remote setup where the CGM device and receiver are outside the patient room. Externalize the IV pump, so the hourly adjustments of insulin infusion through the IV can be made without going inside. And then how the data is transmitted to the nursing station on a tablet, continuous real-time data for them to use, similar to telemetry. Moving down, we see the documentation in the electronic health record and how the comparison is made to the point of care glucose to ensure that we're on track with the continuous glucose monitor. There hasn't been something that's affecting the accuracy. Figure E within the diagram shows the insulin infusion algorithm and the timing for when the glucose is checked, how much insulin the patient's receiving, the target glucose, and below are the glucose inputs into that IV insulin and computerized algorithm. Figure F shows the tracing of the continuous glucose monitor, and also that in times when in critically ill patients, different things can cause signal loss. And we're still learning about those things. For this, it was poor perfusion for the patient at that point. and then it regained signal, became very inaccurate, and then regained signal once the patient was more clinically stable. Figure G shows how the remote viewers or followers can use that real-time glucose data to be viewed remotely. And then figure H shows the glycemic control of the patient and how often they're spending in that target glucose range. So in conclusion, major advances in diabetes technology have included the ability to use continuous glucose monitor values to make treatment decisions. So this non-adjunctive use. Systems have become reliable and available, and patients and providers are able to use that sensor glucose data to make treatment decisions and adjust insulin doses. There have been advances in remote monitoring, data reporting, and management platforms, and progressive integration of the CGM and insulin pumps for automated insulin delivery or hybrid closed-loop therapy, and advancing towards more artificial pancreas technology. Again, remote care is advancing rapidly during COVID-19 in the inpatient and outpatient settings. Just stay tuned for more information as we continue to cope with the pandemic and modify our care for patients. And thank you very much for your time today. Contact information is below.